Yeah, I think the biggest one is that, our older patients tend to not be eligible for trials. So the original Teclistamab studies, again, because of comorbidities, renal function, cytopenias, heart issues, I mean, other things that people get as they get older. And so, again, the majority of these patients would have not been eligible for the trials. And myeloma is a disease of older folks, right? And on average, diagnosis is usually between 65 to 70, younger for African American patients versus Caucasians in that 70 range. But again, that means people tend to have more comorbidities. And so I think this paper was really helpful to say, patients can do really well. The biggest takeaway for me, though, is, a lot of these patients won't get the weekly dosing. Again, toxicity becomes a bigger issue. And so, some of these patients are getting less often, every 2 weeks, every month. There's a lot of supportive care that these patients got. So they still need things like IVIG and PJP prophylaxis and VZV prophylaxis. So again, I think it's really important that it shows that it's feasible, that patients do get a really good response and PFS. But bispecifics do cause a lot of other side effects, especially infections. And our older patients don't do as well with infections. And so that supportive care is really important. But when you do it, they can do really well. So I think we're still learning on how to, all of us should actually, use those bispecifics on older patients in terms of how quickly do we decrease the frequency? Can we do fixed duration? Those are sort of the new questions that have come up. But I think this paper did a great job of showing how once we got the drug in the real world, for these more vulnerable patients, there are ways to already, get them better outcomes by controlling their myeloma, but really decreasing some of those side effects. And the other big thing was, CRS and ICANS. We do see a little bit more ICANS in our older patients because the second they get CRS or cytokine release syndrome, they get fevers and they're at a higher risk of delirium, which will automatically count as ICANS. But with therapies like tocilizumab and even small doses of Dex, they turn around and they do really, really well. So again, it's just about knowing that pathophysiology and intervening quickly instead of waiting for it to get worse. That really turns it around and again makes this much more feasible and improves outcomes for our older patients with teclistamab.